Hello, dear colleagues. It's a great pleasure for me to be here. And now, again, basics, and we are going to speak about inflammations. It's unpleasant situations. Now, toxic anterior segment syndrome. It's a sterile, non-infectious postoperative inflammation condition of anterior segment of the eye that can result in vision loss if not properly recognized and treated. Although first described in the 20th century, still their small reasons and goals are instrument sterilization, intracameral drug preparation, and differentiation from infections and ophthalmitis. Historical overview. TAS was first described in 18th with early reports of contaminated balanced salt solutions and instrument sterilization. Mamalis and co-authors at the University of Utah at 19th were established TAS at ASCRS. There are multifactorial causes of TAS, including enzymatic detergents, endotoxins, preservatives, and medication compounding errors. From 2022, studies have expanded the TAS paradigm to include posterior segment and phakic intraocular lens procedures, showing that TAS reactions are not limited to cataract surgery only. Definition and clinical presentation. TAS is defined as an acute sterile inflammation of anterior segment of the eye, usually appearing within 12-48 hours after intraocular surgery. Clinical signs of TAS is diffuse limbus to limbus corneal edema, anterior chamber cells and glare, fibrin, hypopyon, white hypopyon, elevated intraocular pressure. The posterior segment typically remains intact, helping to distinguish TAS from infections and ophthalmitis, which often presents 2 to 7 days after the surgery. Etiology and risk factors. Recent reports emphasize the multifactorial origin of TAS. First, instrument-related toxins, residual enzymatic detergents, glutaraldehydes, etc. Intraocular solutions, pH imbalance, osmolarity errors, or contamination of balanced salt solution or viscoelastics. Intracameral drugs, incorrectly diluted or contaminated antibiotics, cefuroxime, moxifloxacin, or anesthetics. Surgical materials, silicone tubing residues, ophthalmic viscoelastic devices, or intraocular lens coatings. Newer associations, fibrin glue or sealants, and substances used in minimally invasive glaucoma surgery have been identified as a potential sources. Analysis continue to show that changes in sterilization protocol also can bring to TAS formation. We should distinguish TAS from infectious endophthalmitis, and for TAS, diagnostic features are rapid onset within 12-48 hours postoperatively, absence of vitreous involvement in slit lamp and B-scan, painless or minimally painful eye compared with endophthalmitis, and negative cultures when aqueous samples are analyzed. Diagnostic of endophthalmitis usually presents after 48 hours with pain, with yellow hypopyon, lid swelling, vitreitis. Meanwhile, if we have TAS, empiric antibiotic coverage should not be delayed while anti-inflammatory therapy is initiated. Here you see the table and distinguish TAS from infection and ophthalmit. If young ophthalmologists take a home message and get the photo. Here you see the pictures of the eyes with TAS. We see the white hypopyon. We see intact vitreous, corneal edema. We speak about high intraocular pressure. Also, we have fibrin in pupil size. In the eyes with acute endophthalmitis with yellow hypopyon, lid swelling, and of course vitreitis is very common for endophthalmitis. Treatment and management of TAS in acute phase, intensive corticosteroid therapy is essential. Topical prednisolone acetate hourly. If inflammation severe, we can do subtenon triamcinolone or oral prednisolone. Cycloplegics to reduce ciliary body spasm and prevent posterior synechias. Intraocular pressure control is very important. Beta blockers and carbonic anhydrase inhibitors is vital to protect corneal endothelium, and of course, daily monitoring. You see the eyes before treatment and after the treatment, also eyes after the treatment of TAS. Chronic and late management of TAS. Persistent corneal edema may initiate endothelial cell loss and bring to keratopathy, and then we should go to, DALK. Long-term elevated IOP can bring to trabecular meshwork damage and bring to glaucoma, and then, of course, surgery. And also chronic inflammation can initiate macular edema and fibrosis, and of course, again, go to some difficult kind of surgeries. Prevention. Standardized instrument cleaning, use only ophthalmic grade detergents. Second, dedicated ophthalmic instrument sets. Avoid mixing with other surgical equipment to prevent cross-contamination. And proper medication preparation, use single-use preservative-free intracameral solutions. In conclusion, TAS remains a significant but preventable cause of postoperative inflammation. Although our understanding has improved over 4 decades, new surgical technologies and drugs continue to introduce novel risks. And future work should focus on diagnostic tools to differentiate TAS from infection in real time. Thank you for your attention.
Thank you. It's a clear and didactic talk. So about TAS, several colleagues, and often me, facing this situation, I prefer inject and wait. How you can convince me, do not inject in intravitreal antibiotic, yes. We are alone. It's panic situation. Yes. We are not sure that it's not infection situation. So how we can convince colleague to wait and treat by topic and inject in a...
It's a very good question. I do not like injections in general, but if we find an endophthalmitis, of course we should. But clinical signs are important. We're paying attention to signs, to high IOP, to white hypopyon if there is a hypopyon, and of course steroids. But we prescribe antibiotics to be safe. Not injection, but prescribe as eye drops.